First of all, I would like to thank the GIS committee for inviting me for this elegant meeting. And I think we have to increase our complications meeting, because this is the true messages for learning. And if you want to be a good interventionist, so you have to learn from complications. I will go through my case. He is a male patient, 52 years old. He's hypertensive, dyslipidemic, and smoker. He's a non-diabetic patient, complaining of exertional angina, almost class 3 for 6 months, and stress test was positive and typical of ischemia. His ECG and echo was normal and no segmental or motion abnormalities. Lab investigations only showed an uncontrolled dyslipidemia. This patient had a previous coronary angiography that showed a total proximal LAD, but not non-osteal. It wasn't a non-osteal LAD, and a trial of opening this total occlusion was done, but complicated by dissection and subintimal hematoma, and the patient referred for us 2 months after this trial for further management. And this is the dual angiography. You can see that this LAD filled retrogradely from the right coronary, and unfortunately, the total occlusion becomes osteal. So at that time, I wasn't prepared with an IVUS catheter. So it's now an osteal occlusion of the LAD that fills retrograde from the right coronary, and it seems we have a good collaterals from the right coronary artery. Try to go immediately, a very short trial, antigradely, but unfortunately, the distal segment or the distal filling of the LAD is not good, and it seems that the distal LAD is a diseased vessel. So with the previous trial and dissection, hematoma, so most of the time the wire goes into the subintimal space, and re-entry is very difficult in such a compromised distal lumen of the LAD. So we have an osteal LAD occlusion. It seems a good interventional collateral from the septal collaterals, and also the distal target is not good. It's a diseased distal target. So after this trial of the antigrade approach, we went into a retrograde approach using a microcatheter, which is Corsair Pro, regular sine wire, trying to surf or crossing from these collaterals to the LAD, multiple trials. We couldn't reach, but at the end, we could cross from the collaterals that landed almost very close to the distal cap. And this is the microcatheter inside the LAD. Then using a field RxTR and a Gaia third wire, trying to cross from the osteal LAD into the guiding catheter. And now we crossed into the guiding catheter, which is in the left main. So it's a direct wire crossing in osteal LAD occlusion, Gaia wire now in the guiding catheter. We did tip in, not an externalization wire, so we took a wire antigrade into the microcatheter, and we started an antigrade PTCA. And injection, something wrong. There is no flow in the LAD, and also, if you look at this picture, there is a dissection flap in the left main, almost extended into the circumflex. Oh, sorry. So there is something wrong in the left main. Of course, it's a dissection flap. And in this picture, you can see that there is a filling of the LAD from an epicardial collateral. So we are not in the true lumen, because still after PTCA, epicardial collateral filling the LAD, and we have a dissection flap in the left main. What happened? Why? I went through the left main into the guiding catheter immediately. So there is the dissection, and this is again from another view, and you can appreciate that this flap extended into the circumflex and into the other branches of the left circumflex, into the OM, the high OM branch, and into the other OM branch. So what to do at this time? And what are the missing points? Of course, time matters in this patient, so left main LCX stenting is a life-saving. Patient has chest pain, some hemodynamic compromise, and time is crucial for such patients. So I took a short stent, 4 by 20 millimeter drug-eluting stent from the left main to the left circumflex to secure this dissection. You can appreciate that, of course, there is an extension of the hematoma into the branches or the section, but already I closed the door from the beginning, and this is a large balloon, which is 5.5 NC balloon, to put this stent. And then I recrossed from this stent into the LAD, trying to do an antegrade stenting. And I will tell you why to do this antegrade stenting. Then again, pot. So you can appreciate this is a very good collateral, although it's an epicardial collateral, going from the OM to the distal LAD. So crossing from this collateral, same microcatheter, it's a Corsair Pro, and same wire is the regular sine wire. We can cross into the LAD retrogradely because it's still the wire in the subintimal space in the LAD. So crossing retrograde again. And now I crossed through the stent in the proximal LAD into the guiding catheter, starting PTCA, putting a long stent, then another third stent in the distal part of the LAD. Post-dilatation, and this is the final angiography. There is some residual dissection or hematoma in the distal circumflex, but we closed the door. Don't do more than this in such procedure. Avoid long stenting because we have multiple branches, and all these branches, it seems the dissection extended or the hematoma extended. The most important thing in this case is the messages. First message, don't be overconfident. I am a CTO operator, so no need for the osteal LAD to work with the ideal techniques, which is IVUS. Second thing, don't choose the safest collateral for crossing only. Although septal collateral is safe for crossing and of course safer than the epicardial collateral, but you have to choose the collateral which is safer for the whole procedure. Here, the collateral is landed just very close to the distal cap. So what happened, or what I think that happened in this procedure, that I landed through the total occlusion subintimally, so I went through the subintimal space till the left main, and I crossed from the subintimal space in the left main into the guiding catheter. So choose almost the distal collaterals, not the proximal one, away from the total occlusion. The most important thing, if you are going to deal with an osteal LAD occlusion or osteal LCX occlusion, it's mandatory to have an IVUS probe. Either you are going antegrade or you are coming retrograde, because you have to see that this wire is centralized in the left main or centralized in the vessel occluded by IVUS, because this is very crucial in this procedure, so as not to complicate your procedure from an only crossover stenting into a two stent. And this message is very important. If you tried an antegrade trial and you failed to cross in the true lumen, so you have to keep the wire antegrade for the coming wire retrograde to do a reversed card procedure. So reversed card procedure is of choice in crossing left main occlusion. Don't try to cross immediately into the guiding catheter or direct crossing from the LAD to the left main. So try to keep a wire antegrade and do reversed card technique, and preferably also with the guideliner. And last one, you have to learn from your mistakes. So IVUS is mandatory in osteal LAD or osteal LCX occlusion. Choose the safe collateral, not for crossing, for the whole procedure. Of course, you have to keep wire in the side branch if you are going to do a CTO at a bifurcation, and keep this anti-grade wire in place for further management by retrograde techniques, which is an reversed card technique, and you have to learn from mistakes. And last message, protect yourself from going to these interventions and do regular sports. Thank you.
Thank you very much.